Okay, so welcome, Julia. Before we formally introduce you, you've been invited to our icebreaker conversation, so you'll be joining us for this. Okay, so the question is, if you could find out what year you were going to die, would you want to know, and why?
That's a good question.
I'll go first
Okay.
to save you from going first. I would not want to know, I think. I feel like I would have just anxiety leading up to it, and I already have enough existential anxiety that I think it reminds me to live in my purpose, that knowing would just make me be in grief all the time. So I want to be taken from the mortal plane unbeknownst to myself. So that's my answer.
So you don't think you'd be able to overcome that grief?
I think that I already live in an existentially informed way. I think any further knowledge won't help me.
Yeah, like death comes for us all. So
yeah, like it's also
adding
not like
a date to it doesn't make a difference for you.
No, and it's not a preventable death, I presume. So
no, it's not.
So
it's
yeah, so
inevitable.
I'm good.
Like any attempt to shirk your fate will just bring you closer to it.
Right,
like
and I think I would try to shirk my fate.
Ending.
Right.
Yeah.
Nope. I don't know that Oedipal is used correctly in that term. But
Oedipal. Like,
I know.
Yeah, because like Oedipus tried really hard to avoid his fate and then ended up meeting it.
Oh, I thought you were saying Oedipal in the psychiatric, psychoanalytical
Oh,
way.
no, yeah.
I was like,
not in that way. In the like, I'm going to try super hard and like, not kill anyone and go out and all that like not having sex with your mom and killing your dad kind of stuff. And then, oopsie.
So, welcome.
Is that's why you keep people out of the icebreakers normally?
Yeah, this is usually why. So I would want to know, I think.
You would? Explain.
Yeah, why?
Because I'm a planner.
But how would you okay, continue.
So let's say we ask this oracle when I'm going to die and it says 2026. Bro, I'm not finishing residency. You know what I mean? Like I am taking out a loan and I'm going to spend my money. Like I think that like as I plan a lot of things in my life, even whether it's the next 2 years, the next 10 years, or the rest of the life, I want to adjust that to the timeline I have left. And as of right now, I'm anticipating living till I'm like mid 80s, early 90s. And so everything I'm doing is kind of based off of that.
Yeah,
but if I
greater
found
than
out,
the average man.
It's true.
I am greater than the average man.
Oh, okay.
It's because
10 to 20 years greater.
It's because I have these cats and I read feminist literature. That's how I know I got a couple extra years.
Name one book of feminist literature you've read.
Stregonona.
You haven't read that.
I haven't read it.
You hear that, listeners?
Okay. Nancy Drew.
That's not okay. It is, but that's not.
Yeah, it is feminist literature.
It's not.
It's a jump.
Have you read
Magic
Bell
Tree
Hooks?
House.
Have you read Bell Hooks?
What's that?
And there you have it.
Why'd you do an office stare at the camera?
That was for the ladies listening to this podcast.
Okay.
You should read. I'll make you a reading list. We'll put it on behind the paywall. We'll do a book club. You can have me read things. I truly know nothing about any other facet of your life besides psychiatry. So,
okay.
We're gonna make your feminist literature dreams come true.
I'll finish my answer and let you two go back to passing the Bechdel test for this podcast.
Yeah, we will. We deserve that. So you would want to know.
Yeah, because whether it's like if I'm going to die when I'm 40 or I'm 50 or 60, like I can adjust my timeline to that. And I think at the end of the day, like it's about making what time I have left in my life the best quality it is. So there's a benefit to me knowing how much time I have left. That's how I see it.
Mm-hmm. Yeah.
Okay, Julia, what do you think?
I think I fall in the same camp as Preston, to be honest.
Oh, the right camp.
The right camp, sure. Well, I don't know if I'd be that bold, but I don't know. I also like the idea of like having control over whatever amount of time is left. I was trying to think, would it be worse to like learn I'm going to die in 2 years or like that I'm going to die at 80?
Right. I
don't know. I almost think I'd be more anxious being like, all right, I have like 57 and a half years left. What am I going to do that's like meaningful versus like I have 1 year. Screw it. I'm quitting my job.
Middle fingers to the sky.
Yeah. So
I mean, I feel like what you're both saying makes sense to me. And like, certainly, like, I don't love every single day of my life, but I feel like I really like the ordinary way that I live. And so would it change maybe where I'm living or how I spend time with like family or whatever? Like, yes. But I feel like it puts such a cast over the rest of the time you have that pulls you away out of the present because you know it's ending. It's like when you have like a final couple therapy sessions with someone and you're like aware it's ending. And so there's almost this sense of like, well, should we even talk about things that in a real way? Should we do ordinary things? Or this is ending. So.
But you should always be aware it's ending. Like.
Yeah, but that's different. It's like there's a nuance there between like it's ending and finality. Like we can abstractly know that like we're going to probably die. We are going to die. But like once you actually, once you put that on there, I mean, think about doing therapy with someone. Like if their next session is their last session with you versus you have like another like year and some change and to work with them, doesn't it change it?
Yeah. So my therapist yesterday says,
fired you.
I'm too stable. She's like,
I don't feel that way.
She's like, Preston, I want to make sure that you're getting something
so you've been
out of
lying
these
to her?
sessions. Hey, they were her. She said, quote, I think you're pretty stable, Preston, so we can start talking about termination or just make sure that we're where you want to be with your treatment plan. So
I feel like that's interesting. We won't get into this, but I feel like I feel you have, as any of us do, many emotions that you are working on processing right now. So I'm surprised.
It's funny because we were saying this after I shaved my head.
Right.
Oh my God, you see the dent from the headphones. That's really funny. Okay, I do have something thoughtful to say. If, let's say, so instead of knowing exactly when you're going to die, what if it was a 50% chance you would die in that year or a 30% chance you would die in that year? What does that change your answer?
No, that's worse.
Yeah, that's way worse.
I feel like it like depends on how you are as a person. Like I've had existential dread trying to transform that into meaningful day-to-day life. Like my favorite movie, if either of you have seen it, is About Time. So I feel like my answer would still be the same. And I think the 50% would be worse. It would just make me more aware of my mortality without actually a clear direction of how to use the excess time. What about you guys?
Yeah, I agree. It makes it worse. And I don't think I'd want to know at that point. If I had certainty, I think that would give me some comfort in how to manage my time. But if it just added probability with more uncertainty, I think I'd rather just know nothing.
Would you want to know when the cats were going to die?
No. Dude, I was like literally sitting last night. I was like sitting with Maggie on my chest and I just started crying, imagining what it would be like if I have to put her down.
Your therapist is so right. You're so good.
Well, no, I've already planned it out. Like I'm going to go back in the room with her because I don't want to be one of those like pet owners that doesn't
like I'm going to put down with her.
Yeah, like I'm her whole life. Like I'm her whole world, like outside that yellow chair. And like
Lilac.
And Lilac. But I don't know. I don't want her like final moments to be alone, even though it's going to be.
Well, maybe you'll die first, and she'll be the one.
Yeah. Maybe he'll get put down by the government.
What? Anyway,
wait. So that's interesting. So you'd rather know when you were going to die, but you wouldn't want to know when like your cat was going to die.
Because I think I would treat the cat a lot differently, in a negative way, whereas I was treat my own way positively. I think I would coddle the cats and I would not play with them in the ways that would be like beneficial, I guess. I don't know. I think I would like be trying to grasp at control over the cats, whereas like it would be easier for me to let control go.
You'd be trying to skirt fate for the cats, but not in your own life.
Exactly.
Interesting.
So I'd be like, Lilac, you're living in a bubble now.
Wow.
So thank you for doing that icebreaker with us, Julia.
It's fun.
I think that went awesome.
Yeah. Now we can go into the meat of the conversation, which is actually what Julia does, and that's genetic counseling. So to introduce Julia formally, she is a genetic counselor that works in San Antonio at the Biggs Institute. And you did your genetic counseling at Johns Hopkins in Baltimore. And I do not know where you did your undergrad.
I did my undergrad at UC Davis in California. So I have been, deciding where I want to be in the US by just trial running different states.
Okay, coast to coast. Wonderful. So being in medicine, should know a lot more about genetic counseling than I do. And like Margaret, I kind of know nothing about it. So can you tell us like what your journey was or your decision to go into genetic counseling? And then actually what is your role in the clinic?
Yeah, absolutely. I cannot tell you the number of jokes that I get when I tell people I'm a genetic counselor and they have no idea what it is. And they're like, so designer babies or
Nice.
like, do you tell our genes how to feel? And I just have these like really trite responses that I've come up with. So,
what are your responses?
Yeah, what are your trite responses?
Well, they're more in my head because I feel bad saying them out loud.
Well, now's the time to say them out loud.
Yeah, this is inside thoughts.
I don't know.
We should have named the podcast that.
The counseling genes bothers me. Yeah. But no, so anyways, genetic counseling, for the most part, it does revolve a lot around genetic testing to try and understand, does someone's health condition have a genetic basis? That being said, there are a lot of implications to that, psychological and for family members. And sometimes you learn things that you were never anticipating you were going to learn. So it kind of like, it starts out really simple with this kind of basic conversation around, we're going to do some genetic testing, it might find something, but I think the doors really open when the results come back. And there's a lot of different emotions and thoughts and like sheer information that people don't know that somehow needs to be managed and processed and incorporated into someone's life.
I feel it's a field where a little bit of information leads to way more questions very fast.
Very much so. Yeah.
So a question I would ask you is the concept, I think, in like testing broadly and what tests are indicated, and maybe that people, I think a complex thing in healthcare in general, and I'm sure this is true in genetic counseling, is like the idea that the best care is the most tests or kind of looking at the most things. But then it gets you answers that are may or may not be significant, may or may not indicate something in the future and can cause a lot of anxiety. So I would be curious as well. I'm sure that could be answered a million ways in your field, but how you think about that, or if that's something you have to deal with every day.
Yeah. No, definitely a relevant question. I think the way that plays out most commonly for me is that, let's say that someone comes in and they have a diagnosis. The reality is there are going to be some genes that are really closely linked to that diagnosis, and there are going to be some genes that maybe like 1 to 2% of the time could cause that.
So what's an example of a disorder like that?
I would honestly say probably dementia is not like a bad example of that. So for Alzheimer's disease, there are 3 genes, maybe 4, that are really strongly associated with it. And then there's lots of different conditions that can cause, I would say, cognitive impairment that could easily be misdiagnosed as Alzheimer's. Mm-hmm. And so how broadly you want to be testing is kind of the question. Like, do I stick with the core or do I expand it?
So like I know ApoE is a really common one, mm-hmm. where like if you're homozygous for ApoE, you have an 80% chance of developing Alzheimer's dementia later in life. This is my non-genetic counselor information. So knowing whether I'm like heterozygous or homozygous for ApoE can make a big difference. But then do people want to, like you said, expand the panel and be like, test me for every single gene related to dementia as soon as I find out my mom has Alzheimer's?
I think people tend to lean towards the stance of like, information is helpful. Tell me, and I want to know. I don't know if they always know what they're asking for when they say that, which is a huge part, I think, of what genetic counseling is. It's also kind of reframing expectations and helping people understand what information they'll actually be able to learn or not.
Okay, mm-hmm. So let's say I'm in that scenario and like I want to not only get ApoE tested, what would the other genetic tests I would get be, and like how helpful would they be? Just kind of to go through like one example of one disorder of how muddled this could be.
Mm-hmm. Yeah. So this is a whole nother factor that kind of like complicates things. Genetic testing and what you're going to order might be a little more clear cut for someone who has symptoms and a diagnosis of something than somebody who comes in and says, I don't have any concerns, but my mom at age whatever like had XYZ.
Right.
Yeah. So let's say I'm like 35 and I'm coming to you taking care of my mom who was just recently diagnosed with Alzheimer's dementia via spinal tap, and they confirmed the protein. So now they say, I want to get tested for everything. How would you like approach that?
So my number one rule is testing is going to be most helpful in the person who actually does have the symptoms. Thought process is, let's say there's something running in the family that causes this condition. Who's going to be the most likely to have it? Someone who has the condition. Okay.
So you'd already redirect them towards focusing on the patient.
Yep, absolutely. If you can, start there, because if there is a genetic factor that's causing this condition and you can identify it in someone who has that, then testing for family members doesn't have to include this broad search for all the genes that could possibly be related. You know exactly what you're looking for.
Okay, that makes sense.
Well, we came in, and I kind of am guilty for this because I was like, I have a question, and theoretically in ethics. Preston had mentioned this, but like your story of how you ended up doing this work and what led you to kind of choose it before we maybe get into other of our questions. Be really curious about that.
Yeah. So I feel like I'm a little bit of an anomaly in the genetic counseling world. A lot of genetic counselors are like, I just liked science and I was in college and I'd never heard of this. And then my professor randomly mentioned it. It's not me. I was 14 when I learned about genetic counseling. So
that was me with psychiatry, so I get it.
Yeah, goal directed, I guess.
Was like, it's time.
Yeah, I've gone on long enough with the questions. I'm ready to commit to a career. No. But yeah, I was like really fortunate to go to a high school where they had some classes that were targeted towards people who are interested in science. And so I got to do some really like cool things in those classes, including break open cancer cells. And like one of the cool things about cancer cells is the number of chromosomes is like totally out of whack. So you break it open and there's like this mess and it looks nothing like what it's supposed to. It was just like a little glimpse into genetics and just like kind of sparked something. And I was like, man, this is awesome. This is really cool.
Yeah, it's like the code for life. So fascinating.
It is.
I always thought about that in biochem, like this is a series of ones and zeros essentially, but like nucleotides that can code for consciousness. You know,
it's insane.
It's like unbelievable to think about. Sorry, I interjected. Please continue.
No, I mean, this is like the same fascination I had, because then you start to think about it and you realize that of all the thousands and thousands of nucleotides that make up our genetic code, it takes one difference to radically reshape someone's life. So I thought that was super interesting. But one of the things I really appreciated about that class was they were like, all right, we have a bunch of 14-year-olds who say they like science, like they know nothing about the world. We're going to force them to actually look up careers and things that they could do. Not just like, I want to be a scientist, but like, what are actual paths you could take? What do you actually like? And so in some sort of random Google search that was done when I was 14 years old, I learned about genetic counseling. And it kind of, I don't know, captured my fancy, I guess, in that it was this mix of genetics and science, which I found really interesting, but also these really meaningful interpersonal kind of interactions. And I always tell people I have a made up job because I really feel like it kind of is, but it's like this magical blend.
Well, if you have a made up job.
I mean, all jobs are made up, really.
This is true.
But it's beautiful that neatly fit both your philosophical, sounds like ethical, and then as well as scientific interests, which I think is a very common path to medicine.
Yeah. No, so it was something that I was like, man, I love both of those things. Like rich and deep conversations with people, but also I don't know, the world of science is like fascinating to me, and genetics in particular. And so I figured, well, you have to study something, you have to major in something, you kind of have to set your path towards something. It might as well be this. And if I like it, great. And if I don't, I'll just change it. And here I am years later, still on the same path.
Mm-hmm.
So you're at UC Davis and you're trying to pick where to go for genetic counseling school. How did you end up all the way in Baltimore? And how did your is his master's in genetic counseling? Is that right? How'd your master's in genetic counseling compare to like what you thought it would be like?
Good question. Baltimore is like a fun part of my story in that I was this close to going there for undergrad and decided against it. So Hopkins re-entered my life later, but I had absolutely no control over it. It works like medical residency does, where there's a match system.
For masters?
For masters in genetic counseling. Yeah.
Oh, really?
Mm-hmm.
Why? I mean, why at residency? But like I say, as I'm contemplating my own rank list, but like what? Like I had no idea.
As you enter the match for fellowship right now. Yeah.
Yeah.
Gosh, I empathize. Yeah.
Fellowship in child is better. So, but yeah. But yes, I had no idea there was a match. I didn't know that scourge was present outside of. I knew my friend who's a psychologist like had something like a match too. So it was like for going from undergrad to grad school.
Yep.
That's stressful.
It's fun to like describe to your friends, like, oh, you know, like, what are you going to choose? Where are you going? You're like, no, I'm waiting for this Friday where I get an email.
No, speaking of fate, the fates are going to hold a string and put 2 clocks between it. Well, I guess a question I have for you is obviously both Preston and I are psychiatrists. Is there something like, what do you think what do you wish psychiatrists knew about genetic counselors, or like, how do you interface with mental health? I think there's like, obviously there's a level of grief, anxiety people might experience broadly, but you mentioned dementia. I'm just wondering other things that might overlay in terms of what the work we do and some of the people that listen to us, because I've never interacted professionally with a genetic counselor, the psychiatrist. Preston,
I also haven't.
Do you think there's a role for it, or do you think there's something? I know we're going to talk specifically later about something, a different question in terms of like pharmacogenetics and genetics, but yeah, I guess what's your experience been in working with mental health concerns? I think a couple that come to mind is like Huntington's or some of the other genetic conditions and things that have like a developmental level often do. But yeah, I'm curious what your experience is with that, or what you wish that there would be more of an overlap.
Yeah. I would say broadly speaking, in a way that a lot of genetic counselors might be able to speak to and agree with, I think one of the things that genetic counseling is not necessarily built for, but introduces the need for, is kind of long-term support. So I get to meet with patients and their families at this kind of like critical turning point of, hey, like, especially if we do identify a genetic cause, like there is an understanding of why this happened for the person who's affected. And now there are these really significant implications for family members. And we do have a lot of, conversations around the psychology and emotions of that. It's not just like an information session at all.
But not just like deal with it. Bye, guys.
Okay, bye. Yeah.
I am your genetics results robot.
Yeah.
You will die of dementia later in life.
Girl.
Logging off. For empathy, press 1.
This is why I'm hoping that my job won't be too threatened by AI.
By ChatGPT.
Yeah.
Don't worry, girl. You'll go down with us too.
What does this mean? And the robot's like,
there is no meaning.
For assessment of risk, upgrade to our premium plan.
Oh my gosh.
All you get is the gene.
It's so bad. Oh, no, but I mean, I can do my best to like check in with patients and family members when they come back in, but it's not a practice that's built for this long-term follow-up. But there are some I don't know. I think sometimes people they need that like long-term support. Now they're grappling with a lot of this like uncertainty. And sometimes they need to try and decide, like, do I want to get tested? Do I not? Like things like that. But a lot of their providers or mental health providers don't know a lot about the questions that they're grappling with specifically.
Mhm.
They don't know a lot about the condition in question. And so I think that's kind of tough, that I wish there were more providers who had like a little more insight or at least ability to have medical literacy and like learn
Right.
about the conditions so that the conversations are targeted.
Because, like, from our icebreaker question, it gets complicated really fast as to like, am I going to die in this year? Is there a certain percent chance I'll acquire a condition this year? What does the severity of that condition mean? And I think a lot of therapists or psychiatrists are kind of in the dark trying to answer those questions along with them.
I mean, I think also like if you were, I can think of like, I'm in Boston and I can think of like neuropsychiatrists who are hyper specialized here. And so they can have this conversation, but there's like, like 20 of those people in the country who are like, I specialize in Huntington's psychiatry. So there's that. But then there's also the fact that most of mental health counseling and therapy and support outside of medication is done by non-MD therapists.
Yeah.
So I think even having the background sometimes of being able to read the literature around a disease or being trained for at least the 5 years of like the 4 years of med school and the year of intern year as a psychiatrist offers you a different sort of lens in. But it, like I can imagine, like my friend is a therapist and we talk about things and she'll ask me med questions and it's just a different set of skills in the same way that therapists or psychiatrists don't have as many reps as being good at like counseling and therapy as therapists often. And so, yeah, it would be hard to know how to support and to understand some of this. And at the same time, while every person's grief or anxiety is unique, that being able to hold that emotion should be in theory done well in therapy, but they're not going to see a psychiatrist often because and if they are, they're going to see him for like sadly a 20-minute med check, which offers not as much of maybe the like interdisciplinary overlay unless there's a therapist specialized in that population, which sometimes there is.
I think it's really interesting because I almost like maybe incorrectly put genetics in the same schema as I put nutrition within my like medical education, where it's like you basically have a drive-by when it comes to learning about it. And we don't go in depth into nutrition or diet as much as we should, yet we counsel patients on it all the time. Same with genetics. As far as like my USMLE testing went and the things I learned in my curriculum, it really just kind of felt like a drive-by. And I think that like we have these clinics where we'll have embedded registered dietitians or embedded physical therapists or occupational therapists, but I've like never seen an embedded genetic counselor within, I think like a lot of these like very relevant clinics where people do have these like genetic disorders.
Yeah, I will say too, I think it's interesting. So I work in neurology specifically, and you really want to find a rare career, go try and find neurology genetic counselors.
Really?
You're like few and far between.
Why is that?
The world of neurogenetics is growing. It's growing quickly, but honestly, its roots aren't that deep. And so I think like the ability to even know what genes to be looking for different conditions is something that within the past like 10 or 20 years, we've started to be able to do. And so the need for genetic counselors, specifically in neurology, is growing, but like this is new. This is really new.
Yeah. I think one of the things that blows my mind is the disconnect between the demand for like neurology and genetics and how much supply there is. So there's like 4 or 5 behavioral neurologists that do this type of work in South Texas. And I'm pretty sure that like these neurodegenerative disorders will affect about like 1 in 10 people. So for your like information, Margaret, the wait lists they have are like 12 to 14 months.
That's how ours are here too in Boston.
Like it's unbelievable. So it's just like fascinating to me how strong of a demand this is. Like these are ubiquitous in society, these like neurodegenerative genetic disorders, yet clinical counselor in neurology or genetic counselor in neurology is such a rare career. It's like fascinating to me.
Yeah, and it depends on the condition, right? So things like Alzheimer's, it's honestly, our hands are still a little tied. So the 4 genes that I mentioned, one of those is common. The other 3, I've never seen. Like, I've never seen them come up in a clinic where I see people with dementia day after day. And so I think the demand, or I guess I should say, the supply of genetic counselors in those kinds of spheres, I think will grow again as our ability to actually give relevant genetic information to people grows too.
To do something, to have something that's sort of not actionable, but can be used to change disease course or how they use their life course or medication management.
Yeah.
Okay, so now going forward, there is one spot in psychiatry where we do interact with genetics a little bit, and that's something called gene site testing. Have you ever heard of that?
Give me a little bit more of a description.
Okay. Oh, I get to teach Julia something.
Gosh.
So gene site testing it's basically this way to look at the enzymatic panel of catabolic enzymes in someone's liver. So, for example, we have our CYP450 enzymes, and we have like our 2D6 subset, 3A4, 1A2, things like that. And so we get this panel, and it tells us whether or not some of those enzymes are hyperactive or hypoactive. And then people use that to make clinical judgments about what SSRI someone should try. So, for example, fluoxetine is metabolized by 2D6. So learning which sort of CYP450 enzyme is hyper or hypoactive may inform your clinical decision. This is in theory, yeah. So this is actually controversial in psychiatry. And before I share my opinions, I want to hear what Margaret thinks about like applying CYP450 testing and what the role of that counseling is.
Yeah, I think it's controversial. I think that there are instances, like, I think it's an interesting tool, and if there becomes more of a database, like on the research setting, like that there becomes more information, that would be, I can foresee it being a helpful tool. On the other hand, like, I feel like one of the primary things we learn in med school, or that internal medicine people and like intern year that you think about, and I was raised by a primary care father, so is, what does the lab tell us? Like, does this change management is the question always. And so I can see a future where that would maybe be able to change management. But right now, if someone, let's say you get there's some meds we get levels that it makes sense for, that we have a data, like a bank of data of what's like the normal levels. So like lithium, for example, that we get, that's not a genetic set, but just like a blood level, right? And then there's like lamotrigine that you can get levels for, but you really only get levels for really specific settings because you don't really need them from a clinical perspective in a lot of situations, just because like you can titrate safely, With genetic testing, with like these like site testings, I think that there's, what do you do with it? Like, I think one of the reasons I like have questions about it is because people will get these and they're sort of divorced from their clinical care, and they're like private pay and they're not covered by insurance, which Lord knows, as a psychiatrist, doesn't mean that just because insurance doesn't cover it doesn't mean it's a good treatment. But I think with these, it ends up confusing patients, and they bring it back into like their outpatient or inpatient. And sometimes I try to read it and use it to be helpful, but ultimately it's like, well, is the venlafaxine helping you? I think actually venlafaxine is the one where it can be helpful, because there's a secondary one, desvenlafaxine, that you can prescribe if it misses a certain site of metabolism. But like, if someone's not experiencing side effects, and we learn that they may be like a slow metabolizer of Prozac, if there's no side effects and the med is helping them, knowing that is not going to change anything. Even with people who've tried like 20 meds and then they get one of these, which is the most common thing I see, I still don't know how to use it in a way that is going to change management.
Yeah,
and sometimes I think it just limits things.
People have this idea that it's going to be a roadmap to their perfect SSRI. And I guess the analogy I use when I think about it is, like, I'm trying to find out what soap is best for me in the bath. And whether or not I slow the drain on the bathtub, which is essentially what you're doing with these CYP450 enzymes, doesn't have any input on whether or not the soap works on my skin.
Right.
You know what I mean? So it's like, we're like, hey, it turns out the bathtub drains a lot faster when you use the soap. I'm like, okay, does the soap work or not? You know what I mean? And so while you have this cute test, in a lot of ways, you're asking the wrong question, I think. And I think that's like interesting to me, because it's something we have to push back a lot in psychiatry. And then same with these getting drug levels. So often I had a friend like message me the other day and say like, hey, we have this patient, they're inpatient, and we want to get a lithium level on them. And I was like, oh, are they like manic, or like, are they having toxicity? Like, no, they're just on lithium. We just want to check their level. Like, is that good, or should we like consult psych for that? And I'm kind of like take a moment and say like, well, what's the goal in checking the level? Usually the only reason you check a lithium level if someone is not like manic is if you're worried about toxicity. And so I think for like a lot of these objective tests we have in psychiatry, we mistake the convenience of a number that we get on a report for like relevant clinical data.
You're like it's psychiatry. It's like, dude, I wish we had better tools and numbers. I wish we had that.
But they're like some number better than no number.
And it's like, no, well, because then we're going to think false things. I feel like the other thing, something I've seen have been helpful for some people that can be validating is if there's some really like marked thing of like, oh, you are quote unquote slow metabolizer across the board. In theory, there can be people who really have much more like somatic and like higher side effect burden from medications. And sometimes I think that can almost therapeutically be validating, but I don't think we need the number to validate that. I think ideally we should be like, the side effects you're experiencing are real. These meds have side effects.
The one time that I saw it be relevant for someone else's care is that same scenario. They were a slow metabolizer, and they're having side effects on all these medications, and they ended up prescribing very low doses, like 2.5 of Lexapro or like 15 of sertraline, like unheard of low doses. But because they were a slow metabolizer, they were able to tolerate them at those low doses without having insane side effects like they were at generally like starting doses. But I think that like when you see someone continuously having side effects and those issues and signs of toxicity, that leads you to start looking at what's causing the bathtub to overflow. Rather than starting with, let's just look at the drainage of the bathtub.
Right.
So my question to you, Julia, is, and this is kind of something we come across, which is convenient tests that maybe ask the wrong questions. What do you see in genetics that may be these similar tests that ask the wrong questions and that you have to redirect from?
Well, this is super interesting. I think like so many of the things that you guys have touched on are things that are really relevant to genetic counseling. So kind of this question of like, what is the actual utility of this genetic test? How are we going to interpret the results? Are they meaningful? Are they not? Like that is in my domain as a genetic counselor, very much so. And I think kind of as you guys had mentioned before, like I don't know that a lot of medical education for other providers hits on genetics a lot. And so like as a genetic counselor, a lot of times I am informing healthcare providers about the relevance and utility of learning about genetics. And I don't know if this is the same testing or not, but I mean, pharmacogenetic testing and this idea, right, of
that is basically that.
Yes. So
it's basically metabolic testing. Yeah.
And I mean, and so I've had these results come back for my patients because, side note, when you order a really broad genetic test, like whole exome or whole genome sequencing, it's an optional add-on analysis.
Oh, interesting.
Like, patients can be like, yeah, add that on. I'd love to learn.
What are my enzymes doing?
A car wash, you can just add on like a wax or a leather treatment, just add on my metabolic testing.
Let's check in on what the SIP girls are doing today. Let's find out.
And it's weird because this was not something that like in my training, we really focused on at all. And so I'm curious, honestly, to like see where the future will take us, because the reality is psychiatry and genetic counseling have really had very little overlap. But I think this is an area in which they possibly could in the future.
Do you know why? I think I know why that is. So one of the problem is that once it becomes genetic, in some ways, like firmly genetic, then it becomes organic and it goes to neurology. Like, so neurology, a lot of times, at least in the US, in Europe, this is sometimes different. But so once someone's psychosis is like thought to be an autoimmune encephalitis derived one,
or
neurology
like from Wilson's
manages
disease or something.
Yeah. Neurology manages it. So I feel like it's partially think psychiatry is like, we don't know, but something's not right. I mean, obviously there are studies on like genetic likelihood and like schizophrenia, bipolar, all sorts of things. But I think where there's a concrete clinical role with it, we haven't existed there together yet.
And I think that this is a place where psychiatry needs to change going forward, because I firmly believe that all psychosis is organic. There's just what we've identified and what we have yet to identify. And so if our role in that is just, if we find an etiology, defer, like 200 years from now, as we like elucidate more etiologies, psychiatry is just going to functionally shrink.
I feel like that this is our programs might differ on this, because I like, we do ICU psychiatry here. Like we do, and we have a large neuropsych department here. And so I feel like there's more joint holding these patients, and like the patients who are coming in for like cognitive concerns to like the emergency department, half the time it goes to psych and half the time it goes to neuro.
Yeah, maybe it's like a cultural thing, but I found that the attitudes of a lot of people has been, if we find an etiology, or if we're concerned about NMD encephalitis or something,
sure,
I don't need to know anything about encephalitis from autoimmune disorders except that a neurologist should treat it, has been kind of the opinion of a lot of people. And so I've just been, I think, like unsettled by that. And I think just in general, the idea that like psychiatry needs to treat the mind like a black box, and that we only target the things that don't have organic sources.
Interesting. Well, my med school was at WashU. Shout out St. Louis. Shout out WashU. And WashU is a super, super, super neurobio program. And so I feel like that my first part of training was under the opposite idea of like, not that we have the answers yet, but that this is knowable, and let's figure that, like, let's understand the neurobiology of this, and this is psychiatry. So they had your view in a lot of ways, Preston.
Yeah, because I think you can pivot to have psychiatry approach psychiatric conditions in a way that it assumes they're knowable, rather than kind of the way the DSM is set up right now. And I think if you did that,
I don't know about that. I don't know about that.
What do you mean?
I just feel like there's still so much that we do not know. I think as individuals, we should continually be reading as psychiatrists, as you and I have talked about. But I do actually think in a lot of ways the DSM is what we know so far. It just sucks because that's not very much.
I think like what I'm getting at is that we understand the mechanisms with which someone acquires a like generalized anxiety disorder, rather than I'm saying that this is knowable in the future. I'm not saying we know it now.
Okay. Yeah.
So, but if we operate that is a possibility, rather than we have just identified these symptoms traveling in space together, then it allows us to kind of adapt to a future where we start to unlock some of those mechanisms. Because the way we operate as this kind of like rule out specialty, I think like puts us behind. So like, for example, nephrologists, I would say like are in charge of the organ, the kidney. So anything that affects the kidney, they're experts on. And I kind of wish psychiatry was the same way with the mind. Anything that affects the mind, we should be experts on, but we're experts on things that affect the mind as long as you don't know the organic etiology of them.
I think my experience of psychiatry has been very different than yours.
Okay.
Because I actually, I'm at a program that is also super, super consult liaison psych, which is, I know Preston, you know this, but which is like the psychiatrists who see people in there in the emergency department or the hospital or the ICU, and also have something psychiatric going on while they're medically ill often, which is a very particular way to practice psychiatry. And so I feel like one of the core parts of my residency is like, you better have read 20 papers about delirium in an ICU setting coming off of Precedex, or you're dumb. That sounds mean. They don't say or you're dumb, but like the expectation, I'm not that good at reading MRIs, but the expectation in my program is that you are thinking in the non-black box way. And I think it's because we're a very CL heavy program. Like we have a really good CL fellowship that is like a very competitive one. And so I think that there's a lot of that is like trickled into the residency. But I agree with you, Press. I think that's one of the first things we talked about, like psychiatry, is like, what does it mean to work in a field where there's like a lot known and a lot unknown, which is true in genetics too.
Yeah, it's interesting to hear you guys talk. And I mean, I feel like this contributes to my thoughts of why genetics and psychiatry have not overlapped a lot. Because I think a lot of genetics that has to do with the brain, to be honest, is not changing a lot of clinical management at this point. Like a core function of it is answering the question, why? Like, why did this happen? And so,
but not how can we change it?
Well, I mean, I think that's a goal, right? Like if you understand that there's this molecular basis to something, then that targets the way that we think about how we should treat it. But it's not directly connected right now. Like the vast, vast majority of genetic testing that I do, and I'm describing like the benefits and limitations to people. It's like, by the way, this probably won't change the medications that you're being prescribed, but it can tell us why this happened. And it can tell us if other family members should kind of have their like heads up in terms of, do they want to know? Would this be useful information for them to think about? So if psychiatry, or at least in particular places in the US, is less concerned with this why question, genetics has little to do with it, I think, at this point in time, or there's not like a great marriage there.
It's really interesting. And I think as our career and like the ecosystem of our career evolves, we'll see how much, to what extent that why ends up being incorporated within our clinical management. Because in a lot of ways, it is almost like a didactic exercise. And I think the other camp, I would say, that would argue with me and you would say, learning all of these mechanisms doesn't change the person in front of you and may end up like having you look up a bunch of stuff that's ultimately non-consequential. Just like how we talked about, what does this gene site testing matter if it's really, does the medicine work or not? I think some people have that approach to psychiatry as well. And I think in some ways, like rightfully so, because if they can find the medicine that works best for the patient, helps them live their life in the way they want to, you can make a good argument against going down all these rabbit holes that don't necessarily help. And I think we'll kind of see how those two camps negotiate the future. So thank you for this first part. I want to go into a break now. And when we come back, we are going to do some gene trivia, and it'll be Margaret versus Julia. I've prepared a couple questions.
I don't know.
And then we'll finish up with some closing thoughts.
I hope this isn't embarrassing for me. Who knows?
It will certainly not be.
And welcome back to Gene Trivia. I'm your host, Preston Roche, and I'm joined today by
the do-do-do-do sound.
Welcome back to Gene Trivia. I'm your host, Preston, joined by Margaret and Julia. So we're going to do Jeopardy style for this, so you can just buzz in. Just say like, buzz, and then I'll call on you. And if it's quiet, then I'm just going to like kind of like awkwardly let the answer trail out, and then I'll announce it to you, which is actually what I'm anticipating happening with all of these. So it's really just going to be me telling you the answers. That's how much. That's how much confidence I have.
Are you going to mansplain genetics to a genetic counselor?
Trivia.
No, I'm just kidding. I think that you guys are both really smart, but I'm worried about.
This part is
He's like,
professional
hold on.
Well, I'm kind of like, I'm like looking at the questions now, and I'm like, I think I may
second guessing
have made these a little too
I swear,
niche.
if it's like,
what, like I don't know if these are like reasonable for anyone to get.
They're just like super boring. They're like, what is the exact abbreviation for this gene site?
Okay, that is one of them.
Oh my gosh.
So first question, ready?
Hey, listeners, let us know if you liked this, or you can bully Preston.
Levi Strauss and Jacob Davis obtained a patent for this invention in 1873. That was blue jeans.
Oh, shut up. I was like, well, he has the genes, but like, I don't, what else?
Okay,
next question.
These are the kind of jokes I get when I tell people I'm a genetic counselor.
Okay. So,
this is just Preston's type 5 around genetics. He's like, I'm trying to workshop this for a conference.
This superhero from the mutant subspecies goes by the names Marvel Girl, Phoenix, and Dark Phoenix. What's her name?
This who now?
This superhero from the X-Men franchise, or from the mutant subspecies, also goes by the name Marvel Girl, Phoenix, and Dark Phoenix.
Is this fun for you?
That was Jean Grey. I feel like there's a theme we could pick up on here. Yeah.
I didn't know that. That's never been a thought. That name has never been in my brain. This isn't Levi's. I was like, okay, I get it. And then you're like, this, and I'm like, I don't know. Sorry.
Okay.
Sorry, I was outside. Not reading.
Have you seen those TikTok comments where it's like, hey, can anyone explain? Sorry, I'm employed.
Hey, sorry, I have friends. No.
Okay. All right.
Sorry, it was cool.
We're over 2. Let's make it over 3.
Oh boy.
This Swiss psychologist, known for his work with child development, started the International Center for Genetic Epistemology in Geneva in 1955.
Buzz. Is it Carl Jung?
Margaret.
Who is Carl Jung?
Think.
Swiss?
Wow.
1955.
That was Jean Piaget.
Oh. I didn't know he was Swiss. That really threw me. I guess Carl Jung wasn't either, but I felt more like it might be.
Like, you could just say, for all these, you could just answer it and said Jean, and you would have been right.
Now I'm having more fun getting them wrong.
I'm trying
more fun having them wrong.
I'm like, I gave it to you guys, like
women, they never get it.
I know. Like, you just had, all you had to do was just buzz it and yell Jean. And we would get on all these trivia questions.
Now I'm in protest and not gonna.
Okay. This phenomenon occurs when trinucleotide repeat disorders increase in severity within the progeny of carriers of the disease.
Buzz.
Julia, buzz in first.
I'm going to assume what you're referring to is anticipation.
Yeah, it was anticipation.
Okay.
Because I didn't want you to anticipate that the 4th question was going to be genes again. So we had to switch it up.
Good thing we didn't catch on the first 3. We weren't anticipating shit.
No risk of that.
Okay. And the final question, which you did anticipate. This gene, known for its relationship to achondroplasia, a disorder that affects the growth of long bones, goes by what name? Or what are the letters associated with it? You can say either.
I should know this. And I think I know it, but I don't.
That was FGFR3, fibroblast growth factor.
That sounds like something I knew one time.
So this has been Gene Trivia with Preston. Our contestant got 0 answers right.
She got one.
Sorry.
Whoa,
what?
Whoa.
I am so sorry. Julia has won gene therapy with your excellent question about anticipation and this increased severity of trinucleotide repeat disorders. For final gene trivia, I want you to write down on your whatever paper next to you, what are the 3 trinucleotides in the repeat associated with Huntington's?
Oh, I don't remember.
Yeah, this is just solely to embarrass Margaret, so I can have Julia dunk.
Did you hear any of those first questions you asked?
They were all genes.
I know, but it's just a vibe.
Reveal your final trivia answers.
I didn't write anything down.
Oh, okay.
I literally don't remember. I remember like Friedrich's ataxia, sort of.
Okay, what is that answer, Julia?
Should be CAG.
Yeah,
CAG.
I always remember from the sketchy, like the CAG pants, cargo pants with Huntington's.
Oh,
so
I remember like the big guy like falling over. Isn't it for Friedrich's ataxia?
Mm-hmm.
What is Friedrich's ataxia's repeat?
I know the number that you need, but I didn't look into the actual nucleotides. You need 66 or more, but
the number of nucleotides. That's interesting. So now, if you wanted to talk to someone who is thinking about genetic counseling, what would you counsel them on?
Is the Friedrich's ataxia. Sorry.
Oh, yeah. Yeah.
That's because he's like, God, and he's falling over his feet in the sketchy. Anyway, real question.
Okay, wait, repeat that.
So let's say there's a 14-year-old who just took a science class where they got to crack open some cancer cells and they're interested in genetic counseling. What would you tell them about this career field?
I mean, I think if they just wanted to know about it, I'd probably give a pretty similar overview to what I gave you guys earlier. But I think one of the things that's cool about genetic counseling is that, again, it's a really new field. And so that means a couple different things. It means you're on the forefront of the knowledge that's growing. And so like I work with patients all the time where I'm telling them about the gene therapy trials that are happening. And like we are like right at that intersection. And this is like an exciting place to be where we are constantly learning new things. And so it is exciting. And also like it's fun to have a career where you're kind of needing to always learn more because it's not like a settled, yes, we've known this forever. And I'm just here to kind of like disseminate information. So
what would you caution them on?
Or who would not? Who do you think should not would like be a bad fit, but maybe this job would not be? Because I presume that you have a lot of hard conversations. And so I wonder if there's anything that you didn't know before going in that's like, this does kind of weigh on you in this job. There certainly are those things in psychiatry.
Yeah. I almost feel like that's advice that I'd give to people who are already kind of on that path, because I think different specialties in genetic counseling, like depending on what healthcare field you're situated in, feel really different in terms of the conversations you're having. So one of the reasons I really liked neurology is because sitting down and talking with someone about whether or not they want to learn if they're going to develop Huntington's is not a conversation about what screening then you'll be able to do or what treatments you're going to take. Like it is a personal, tell me about your life. Tell me about what you would do if you knew and what you would do if it's positive or negative. And like, let's just talk about life and what this information means to you.
Right.
So like really putting the counseling in genetic counseling.
Yeah. And there are other places where those conversations for predictive testing, where someone's asymptomatic, but they just want to learn like what will happen. It's much more information focused or targeted to like, these are what your next steps would be.
These are the screenings, here's prophylactically. I'm thinking of like the BRCA, like things where it's like, there's like a very, here's what we're going to do, here's what we can do. And maybe if you're someone who likes focusing on that more and optimizing that, or if it's really, really tough for the gray to be there, then that would be like something that would help someone in the field.
Buzz.
Wait, is that a person or a color?
This is a person, the mutant from the subspecies of X-Men, also known as Marvel Girl, Phoenix, and Dark Phoenix, Jean Grey. It was question number 2 from Gene Trivia.
I don't. Sorry, I'm employed.
I was making a pun. Okay, well that's all the time we have. So Julia, do you have anything, any promotions or websites, social media profiles that you would like to promote or shout out?
Any genes you're selling?
Any gene testing?
No, I honestly, I don't.
She's super ethical, you guys.
Yeah. Any conflicts of interest?
Nothing to disclose.
She's working on the X-Men comics or whatever you're saying.
That's fantastic to hear. And then anything that you want to bring the public's attention to then, if you don't have anything personal.
Yeah, this is your moment to platform something.
Julia's into baking.
This is true.
Now's your chance to so I'll tell this story. The other day she brought in zucchini bread.
Nice.
For the office. And no, not nice. People like slammed it. And they were like, why would you put a squash in bread? And I grew up with zucchini bread. And I was like, oh, I love zucchini bread. My mom made it all the time, And so they're like, Julia's like, Preston, can you validate me? Like zucchini is normal in bread? And I'm like, I would, but she was getting blasted in the workroom. So I was like, I've never heard of putting a squash in bread. That's weird as hell.
Unfortunately, I'm going to abandon
and then I secretly
you.
went
See you on the podcast, though.
Yeah. Right. Well, this is fun to hear Preston's version of the story. Slightly different than mine.
But in secret, I was like, please bring more zucchini bread. I love it.
Right. That's why he didn't try any when I brought the zucchini bread in. But I
ate a lot of the zucchini bread.
Preston, do you cook?
No.
Period.
I'm just kidding. I'm trying to get better at cooking. I went to a class at the Culinary Institute.
Oh, cool.
They have one in San Antonio, and I learned how to make ratatouille.
Oh,
and
fun.
I made some at home the other day. Yeah.
That's cool. I'm taking a cooking class in January, so I get less depressed during the winter. But I'm taking it at the Culinary Institute in Boston, and it's like 6 weeks, and it's like 4 hours each time. And
Hell yeah.
and apparently they're kind of mean to you, and I'm like, hell yeah, I need like
Dude,
a
the-
Chef
Gordon
Miranda
Ramsay.
Priestley.
No,
Like,
the yes chef thing, no chef, it's so real.
I'm excited.
It's they feel like attendings, but for cooking. It's so
I
interesting.
love it. I need more of that. There's not enough energy like that anymore in psychiatry, so I need to get.
No, that's what I'm saying. Like,
get on
no,
it.
like I was like cutting the ratatouille in the class, and like the like resident equivalent like comes over and he's like, oh, the like ratio of eggplant to like onion isn't good enough. And I was like, what do you mean? And he's like,
"You're
we
so
need to cut these
stupid."
eggplants. Yeah. So the ratio matches in the stew. And then like the chef comes over and she's like, what's with this ratio? And he's like, sorry, chef, we're going to correct it right away. I was like, oh man. I'm like, he's like, who cut this? I'm like, I point to like the 12-year-old. I'm like, it was Peter. It was Preston. But
Preston's in like a kid's
He'll
cooking
never
class by
know.
himself.
yeah, I have like the
Everyone was there.
giant like
It was like
paper hat on. It
Ratatouille
looks
themed.
so
It was
dumb.
for kids. And Preston's like, I like Ratatouille too. What?
It's so funny. It's a good dish, actually. Like it tastes pretty good.
I believe it. I believe
I
it.
know.
Mostly, from the movie, but
Yeah, did you know that the dish existed before the movie?
now now you're saying that's like saying like
No.
France existed before Epcot made it. Sorry, France. I'm kidding.
So your fun fact about ratatouille today is it was a peasant dish designed to extend the life of vegetables.
Oh, that makes
So
sense.
if you had a vegetable that was like kind of like 2 days from going bad, chop it up and throw it in a stew, you get an extra 5 days out of it. So all these French
That's very
peasants,
Stregonona of you.
they would go through their pantries and be like, oh shoot, I got these like peppers, eggplant, squash, zucchini. Let's just cut them up and throw them together, mix some salt in there, and then you got ratatouille. It'll last you a couple more days. So it was born out of necessity, and now it is a delicacy in the world of fine dining, and also a blockbuster film. Okay, so thank you so much for listening. How was the show? Did we stay on topic? Let us know if we didn't.
We certainly didn't, but I don't think you guys
want
want
to
to
hear what you think. Come chat with us at our Human Content podcast family on IG and TikTok at Human Content Pods, specifically about what you thought of Gene Trivia. I want to get your feedback on that because I
Preston will
like
do
Gene
his own
Trivia. I would like to
episode
do
with more
more
questions
Gene
like
Trivia
this.
segments.
Speaking directly to camera.
You can contact the team directly at howtobepatientpod.com. Shout out to all of our listeners who left kind feedback. And
the
shout
ones
out
who
to
bullied us positively. We're going to get better because of you
bullying
guys.
works on me specifically. I have a very weak sense of self. If you bully me again, I will probably read it and also only remember it for the rest of my life. On YouTube, full videos are available each week at It's Presro, which is just like my normal YouTube channel. Thanks again for listening. We're your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer.
Preston.
And Margaret's also a producer.
I'm going to kill you. You need to edit this section. Yeah.
Yikes.
It's not his fault.
The glass ceiling just gets to me sometimes.
There was a tweet today that, never mind, I'm not going to go with this.
Our editor is Tracy Barnett. Our music is by Omer Benzvi. Check out our show notes to see the references and resources we use for this discussion. And to learn more about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to our website, howtobepatientpod.com, or reach out to us at howtobepatient@human-content.com with any questions or concerns. How to Be Patient is a Human Content production.
Bye, Gene.
Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.